Good morning again. My talk is diagnosis and testing of PAD. I'm going to start with a little bit of epidemiology to look at the scope of this disease and go over the modalities of testing, the angiosome, and some anatomy. Conflict of interest for this presentation is none. So the peripheral arterial disease, as you know, it's systemic atherosclerosis that affect the lower extremities, anywhere from the abdominal aorta down to the toes, leading to foot ulcers and gangrene. That's the worst presentation. The risk factors are diabetes, smoking, chronic renal insufficiency, older age, hypertension, hyperlipidemia, genetics, and there is a prevalence of PAD slightly higher in men than women. The scope of that, almost 16 million people in the US have PAD. There is low awareness. 19 to 26% of people are familiar with their PAD, and 11% of the patients in the US are associated with critical limb ischemia. Also, there is a disparity that we're becoming more and more aware about it. Women with CLI are more likely to have worse outcome upon diagnosis, which leads to decreased mobility, poorer function status, and higher rate of death. Same with the minority. African American, they have twice the rate of PAD compared to the white, yet they're underdiagnosed and undertreated. Even in research, minorities and women are underrepresented in the research. There in women is almost 25%, 27%, in Hispanic and Latins is around 7%, and the same in American African population. PAD presentation, as you all know, it can be present in different ways: asymptomatic, atypical leg pain, intermittent claudication, critical limb ischemia, and acute limb ischemia. And the Rutherford classification goes from 0 to 6, 0 being the asymptomatic, 1 to 3, mild, moderate, and severe claudication, and critical limb ischemia, class 4, 5, and 6. 20 to 50% of the patients are asymptomatic, 40 to 50% they present with atypical leg pain, and 1 to 2% they have critical limb ischemia. The natural progression of the disease, 10 to 35%, like it's mentioned before, have claudication at the initial presentation. At 5 years, 15 to 30% are dead, and 20% they have non-fatal cardiovascular events. Limb morbidity at 5 years, critical limb ischemia again, and 1 to 2% of the population that have initial claudication, 10 to 20% they have worsening claudication. The survival risk and amputation, once you go into this route, mortality and major amputation risk increase with worse initial presentation. And this is a graph to the right, the 4-year survival by initial presentation. The worse the presentation, the worse will be survival over the next 4 years. Now, going to critical limb ischemia, the most patients are present with multiple levels of CTO. They have multiple levels, and often they require multiple intervention and higher procedures. 30% of them, they're above the popliteal segment, 10% at the popliteal segment, and 30% at the infrapopliteal vessels. Going to the critical limb ischemia, the risk factors for that, age above 65 years old, lipid abnormalities, ABI less than 0.7, smoker, and diabetes. So out of those patients who present with critical limb ischemia, at 1 year, 45% that will be alive with 2 limbs, 30% that will be alive and with amputation, and 25% that will be dead. The one that they are alive with 2 limbs, they'll either their CLI 25% resolved, or the 20% of them that will have continuing CLI and wounds. Oh, sorry. And Like mentioned before, those patients, they have multiple level of occlusion. The trend in critical limb ischemia, they have the admission rate is 150 per 100,000 population in the US. There is significant reduction in the proportion of patients undergoing surgical revascularization, and then currently there is an increased rate of endovascular revascularization. Causes of readmission after endovascular therapy for CLI: unhealed wounds, multiple wounds, older age, female sex, people who have end-stage renal disease, and history of heart failure. The lesion land, they have extensive disease. Most of them, they have lesions extending between 50 millimeter up to 15 centimeter in the infrapopliteal vessels. Going to the anatomy, as you all know that at the level of the popliteal artery, the artery is divided into three vessels: the anterior tibial artery, the peroneal artery, and the posterior tibial artery. Going down to the foot, the anterior tibial artery feeds the dorsalis pedis, the lateral tarsal artery. The posterior tibial artery will feed the common plantar artery that would divide into the lateral plantar artery and the medial plantar artery. They connect by the arcuate artery, the deep perforating branch, and this arch will give rise to the dorsal metatarsal arteries. That's another scheme of the anatomy of the foot. And this is a prototype of the anterior tibial artery, dorsalis pedis, the location of the arcuate, and the dorsal metatarsal artery. Why am I presenting this? Because this is important in the wound healing and the angiosome distribution. Back in 2002, Dr. Shishupur had a paper about the angiosome and correlating with the wounds. This is another scheme of it. Everything that represented in red is supplied by the anterior tibial artery. In the blue is the posterior, the peroneal artery by the lateral calcaneus branch. Everything in the green is the posterior tibial artery and the lateral plantar artery. Yellow is being fed by the posterior tibial artery and the medial plantar branch, and the violet color is by the posterior tibial artery and the medial plantar branch. Now, the diagnostic tools for PAD and critical limb ischemia, ABI is the first test. However, the ABI have different, multiple downfalls, especially in diabetic patients, where mostly the vessels are calcified and non-compressible. So the next test, and it will be erroneously elevated. So the next test will be the TBI, leg segmental pressure, and pulse volume recording. Invasively, we have the the DSA, endocyanine green, and skin perfusion pressure, which are not performed at this point, or they're not popular at this point. However, they're good indicative of the perfusion pressure. Non-invasive, we have the duplex ultrasound, which is, in my opinion, it's good for above-the-knee vessels. But when you have somebody with a multi-level disease and multiple lesions below the knee, the ultrasound is sometimes erroneous in delineating what's obstructed, what's not obstructed. CT angiogram, it's another modality to diagnose the anatomy. However, sometimes in diabetic patient and stage renal disease patient, with their heavy calcification and the blooming effect of calcium, it will be very difficult to recognize this or estimate the significance of the lesion. This is an example of a normal ABI, where the vessels are compressible, and the normal ABI ranges between, it's above 1. Anything above 1.2 is calcified vessel. This is the one where we have a calcified vessel. The vessels are non-compressible. However, the TBI is normal with 0.93 and 0.85, respectively. And on the right side It's another one where, again, the vessels are not compressible, however, the TBI is low. In the critical limb ischemia, I compare it often to MI or angina. It doesn't make a difference what the stress test has shown or what the echocardiogram has shown. If somebody is complaining of chest pain or they come in with EKG changes, you take them to the cath lab. The same thing with critical limb ischemia. If they have wounds and it's not healing, despite that you can feel pulse or the ABI might be borderline, the test of choice will be invasive angiogram to delineate the anatomy and look at the infrapopliteal vessels, and more importantly, to look at the below ankle vessels. That's the latest example where this patient presented with a plantar wound that have been labeled for pressure ischemia. He had decent ABIs, however, the wound was not healing over a period of a few months. It was referred to us. An angiogram was performed, and I don't have the pointer here, but his disease was, this is the final angiogram after angioplasty. His disease was at the level of the common plantar artery and the medial plantar artery that feeds that angiosome. And this was open and dilated, and the wound has been healing since. So awareness about the critical ischemia is important. Immediate referral and working with vascular interventionist is very important. And angiography before amputation and in a slow healing wound is critical in those kind of patients. Thank you.